form of the object and the color of the object. So they're actually for different perceptions of an image. So it's just, you know, from the retina, you can see there's already lots of different information obtained from this light that lands on the retina. And all this information has to be transmitted along the visual pathway all the way to obviously your primary visual cortex without losing any of this signal if you are to produce the correct image of what you're trying to see. So you can imagine a lot of things potentially can go wrong with this pathway. So I'm not going to talk about this in a lot of detail, but just for completeness sake, there are big differences between the rods and the cones. As you probably know, there are a lot more rods than there are cones. The cones are all kind of concentrated around the fovea, which is where you perceive visual color, and it's got very high acuity. And the reason why cones is able to perceive color vision is because there are 3 different types of cones, and they have therefore 3 different types of photoreceptors, and they detect light of different wavelength. And then depending on how many of each of these 3 types of cones are activated, the brain can then work out where along this light spectrum the wavelength is actually falling, and therefore will give you the perception of that particular color. So you have, you know, the 2 extreme and the 1 in the middle, and then depending on how many of each receptors are activated, it will work out where along the wavelength is, and therefore tell you this is, you know, rose pink or aubergine purple or whatever it is. So that's how color vision comes about. Whereas rods only have 1 type of photopigment, which is why it cannot produce color, and this is a grayscale when you're using rods alone. But as a result of only the 1 type of pigment, the rods have a much higher sensitivity to light, and therefore it can even detect very dim light at night. So your night vision is all based on rods, which is why when you're looking in the dark, so say in your bedroom at night when the lights are off, you can see things, but it's all in a grayscale. You don't really see color unless you've got a little bit of light coming through. The other thing about rods is that it's able to amplify your signal quite significantly. So a single photon falling onto a rod will activate it and give you a signal going to the brain. But cones are unable to do that, and you're going to need quite a lot of light landing on that 1 cone receptor to trigger a signal, which is also why, once again, at nighttime, you're unable to see color very well because you don't have enough photons going onto your retina. Now, this is probably the most important take-home message, is that the retinal image is an inversion of your actual visual field. Now, lots of people will know that when we're talking about lesions to the visual pathway, whether it's the optic nerve, the optic chiasm, the optic tracts, it's always the opposite deficit to what you get. So, for example, if you damage the right optic tract, you get left homonymous hemianopia. If you damage the right occipital cortex, you're going to get a right homonymous hemianopia. So it's always the opposite side. You know, pituitary lesion hitting the optic chiasm from below gives you an upper quadrantenopia. So it's always the opposite. And if anyone ever asks you why is it the opposite, it's not because of the way the fibers are arranged, it's because of the way the light lands on your eyes. So if you imagine looking forward and you fix on a particular point, which is where your fovea would be fixed on, anything that's to the left of that fovea, so that left hemiretina, is picking up light from the right-hand side, and vice versa. And the easier way to remember this is you hold a torch and you shine it in your own eyes from in front. You've got equal amount of light coming onto your eye. But as you move the torch towards your right-hand side, it's coming onto the left side of your eye. And if you move it onto the left-hand side, it's shining onto the right side of your eye. So the right side of your eyes, so we're not talking about nasal and temporal here, we're literally talking about left and right. The right side of your 2 eyes are picking up light from the left side of your hemifield, which is why your image is always the opposite side. And that's the reason why lesion to your optic pathway causes a deficit to the opposite hemifield. It is just purely physics that the light lands because of the way it is reflected. It's actually very simple. If you don't understand it, you probably shouldn't be doing medicine. Anyway, sorry, I probably shouldn't say that. So that's a very important take-home message. Everything is the opposite side to what you think. Okay. Now, from the retina, the ganglion cells then obviously projects backwards through your optic nerve. And once again, we'll go into this pathway in a bit more detail, but you've got optic nerve coming back, forming your optic chiasm, optic tracts, and then it ends in mainly 3 different places. The first is the lateral geniculate ganglion, which is one of the ganglions within your thalamus. And from there, you've got your second order neuron that goes to the primary visual cortex. There are also some fibers from your optic nerve and optic tract that goes directly to the brainstem area, to the superior colliculus for control of eye movement, and to the pretectal area for control of your pupillary light reflex. So we'll look at that in a little bit more detail in a minute. This is a slightly zoomed in area of that lateral geniculate ganglion, just to show you how some axons go directly into the LGN, some axons come to the pretectum, and some axons go to the superior colliculus. Okay, so that's pretty straightforward. So just dealing with that pretectal area first, because that's a simple one to look at. So once again, just a quick summary: light comes onto your retina, travels down the ganglion cells or optic nerve, and it bypasses the LGN because this is the pathway that goes straight to the pretectal area, which is in your midbrain. From there, you have bilateral projections to both of the Adegbaeyego nuclei. The Adegbaeyego nuclei is a parasympathetic nucleus that is next to your third nerve nucleus in your midbrain. Okay, and so the postganglionic, or actually, sorry, the preganglionic axon that comes off the nucleus runs alongside your third nerve, as you can see here, all the way to the ciliary ganglion, where it then has a postganglionic axon that projects to the ciliary muscles in your eye that controls the actual pupillary reflex. So when you shine a light, say in this particular case, into say the left eye here, you have light traveling down the left optic nerve all the way to the midbrain, but it then stimulates both the left and the right Adegbaeyego nuclei, and therefore you now have signal traveling along both the left and the right third nerve to the ciliary ganglion and back to the eye, and that's why you have your direct and consensual light reflexes. So if you shine the light in one eye, you get pupil constrictions in both eyes. So if you shine a light in one eye, that eye doesn't react, but the other eye does. It means that the light is being seen by your optic nerve, but that the third nerve is damaged, and therefore that pupil can't restrict. So that tells you that that third nerve is damaged. If you shine the light in the eye and neither pupils constrict, it means that the optic nerve is not seeing that light at all, and so you've got an optic nerve injury. So this is how you can tell when you test direct and consensual eye pupillary reflexes whether the lesion is involving the optic nerve or whether it is involving the oculomotor nerve of one or the other eye, by seeing whether both eyes constrict simultaneously. You can actually also do the RAPD, which is your relative apparent pupillary defect, which is when you do your swinging eye test. And the reason for doing RAPD is sometimes the pupil constriction is subtle and you may not be able to spot it, especially if you're in a bright light environment or the pupils are relatively small. But by swinging the light from one eye to the other, and you have to do it slowly, so doing this quickly doesn't work. You have to give time for each eye, one after the other, and the eye that has the subtle third nerve palsy will constrict so slowly that by the time you swing it back to the other side, that other eye is already constricted, and it gives you the apparent kind of illusion that that pupil is actually dilating. It's just because it's constricting slower than the other side. So when you do your swinging eye test, you'll see one pupil look like it's dilating when it isn't. That's the eye with the third nerve palsy. Anyway, that's enough about pupillary reactions, I think. The main thing here is that you've got bilateral projections to both Adegbaeyego nuclei, and that's why you get consensual reflexes. Back to the actual vision and seeing things. So we talked about the light coming along the optic tract to the lateral geniculate ganglion. So the thing to remember here is that you've got light coming from the left-hand side landing into the right hemiretina, and that light projects down the right-hand side, so on the same side, to the lateral geniculate nucleus on this right-hand side, which, as you can remember, represents the light from the left. which is why it's all opposite. The LGN is quite interesting in that it is actually divided into 6 layers. Layer 1 and 2 governs your M channel, which is, as you remember, the magnocellular channel, which is the growth features and the movement. And channels 3 to 6 are your parvicellular axons or ganglion cells, which is your P channel, and that's for form and color, as we talked about earlier on. So you've got 6 layers within the nucleus, and each layer also represents either the contralateral or ipsilateral fibers in an alternating fashion. So it is actually a very logical arrangement to ensure that all this information is kept separately and not mixed together, and therefore you get cross-wired. There are actually separate axons and separate nuclei representing each of these perception of form, features, movement and color, so that all of this can be projected to the correct cortices and subcortical areas and processed accordingly to give you the correct image ultimately. Okay, and ultimately all of these project to your primary visual cortex or Brodmann area 17, which is obviously in your occipital lobe. Okay, I'm not going too quickly, I hope. Do stop me if I'm not making any sense, okay? So we looked at the structure of the retina. We've looked at the structure of the laterogenic ganglion. We now have to look at how that light actually goes from the retina to this the nucleus. Okay, so we're now looking at this kind of X-shaped pathway in the middle. So the actual fibers. And this is a picture stolen from the book by Patton, Neurological Differential Diagnosis. If you don't have this book, it is the best book you can get for neurology and neurosurgery. I think I spent years trying to understand the visual pathway, you know, what goes where and why this lesion gives you that problem. And then I read this one chapter in this book, which is about 5 pages long, and suddenly I've remembered it for the rest of my life. Well, until now. Maybe one day when I get dementia, I'll forget. So it's a really good book. Do get it. What you can see here is the optic nerve at the front coming back, optic chiasm here, and then your optic tract coming back. And if you follow any one of these fibers they've drawn, they show you how these fibers run along this tract. So it's a really clever diagram that you have. But essentially, you've got fibers coming through the optic nerve. Some of them, mainly the ones on the temporal side, stays on the temporal side and continues down the optic tract on the same side. So that's same in both eyes. The nerve fibers which are on the nasal side, some of them will still stay on the same optic tract, but some of them crosses to the other optic tract. So there is a crossover of signals, some staying on the same side and some crossing to the other side. And that crossover is obviously your optic chiasm, which is sitting just above your pituitary gland. So if you look at the fiber that I've colored in red, so this is your nasal inferior field, you can see that coming along the optic nerve here, crosses in the optic chiasm, and actually even the optic chiasm has very specific organization in that the inferior field crosses first at the front and the superior field crosses last at the back. So the organization is not chaotic at all. There is a very logical representation of all the different signals from different parts of your retina. And then, as I said, within each of these fibers, you've got the separate axons that carries all the different types of information about motion and form. So it's highly complex. But as these inferior visual field fibers coming through and crossing the optic chiasm, it doesn't come straight back. It actually goes forward into the contralateral optic nerve slightly before it curves back along the optic tract. And that little bend at the front is called the anterior knee of Willebrand. And because of that, if you have an optic nerve lesion that crosses that loop, you have a very specific type of visual field defect called a junctional scotoma. I'll show you that in a minute. That only happens with your nasal inferior field fibers, as you can see. Your nasal superior field fibers don't do that, and your temporal field fibers, well, they don't cross, so they just keep going forward. So it's just that inferior nasal field fiber that gives you the anterior knee of Willebrand. The other thing to note on this particular diagram is when the fibers come into the optic tract, they don't travel straight in the optic tract. they start to twist and turn. Can you see? If you follow any of these, say like once again, the one I've colored in red, it's traveling on the medial side of the optic tract at the bottom, and then at this point it's crossing over to come out into the middle. And similarly, if you follow, say, this temporal ipsilateral fiber coming back here, it's crossing still on the ipsilateral temporal side, but then at this point it suddenly jumps upwards into the superior side. There is actually an anti-clockwise rotation of all the fibers. That's basically how it works. All the fibers come straight back, passes the optic chiasm point, and then they start to rotate in an anti-clockwise direction just for 90 degrees and no more than that. And that twist also has a big significance when you have a lesion to the optic tract, and we'll come to that in a minute. So junctional scotoma. Here's another representation. Your inferior nasal field coming through, inferior nasal retinal image coming through here, and then moving forward into the contralateral optic nerve before it comes back. If you have a lesion across here, obviously you take out the whole of that eye, so that eye is gone, hence you can see the visual field here completely black. And then on the opposite side, you've taken out that nasal inferior retinal image. And remember of the torch thing, you know, to get an image down here, that light is coming from the opposite direction. So it is the temporal superior quadrant that is gone. So you get a contralateral superior temporal quadrant tanopia along with the blind eye. That's called junctional scotoma, and that tells you the lesion is at the back third of the optic nerve affecting the anterior knee of Willebrand. So that's actually quite an important visual field to detect and recognize if you're trying to be clever and work out where the lesion is. The alternative is say that the patient's got visual field defect, you're getting an MRI scan. That's 21st century medicine. For the chiasm, I think most of you know about this. Everyone knows pituitary tumors give you a bitemporal hemianopia. But then how can you tell, say, the difference between a pituitary adenoma and a craniopharyngioma? They're both in the pituitary area. How do you know what's causing what? Well, a craniopharyngioma tends to grow from above downwards. A pituitary adenoma tends to grow from below upwards. So if you've got pituitary adenoma, you've got inferior compression, you're affecting the inferior hemiretina, and therefore it's the superior field image that is being affected. So if you've got pituitary adenoma and you catch them early enough and you do a visual field test, you start off with upper field defects first. And because the tumor is in the midline, you're affecting those crossing fibers from the nasal side of your retina. It therefore affects your temporal visual field, and that's why you have a bitemporal upper quadrant anopia. Completely opposite for craniopharyngioma, growing downwards from above, affecting the upper visual field, affecting the upper visual fibers, and therefore it's the lower visual field that's affected. So you get bitemporal lower quadrant anopia. Obviously, if you leave it for long enough, they will all get a bitemporal hemianopia, and if you leave it for even longer, they'll all just go blind. So it depends at what stage you pick it up as to what visual field defects you're going to pick up. Now, back to the optic tract and this 90-degree twisting that I'm telling you. Why is that important? Because this gives you something called incongruous hemianopia. So everyone knows about homonymous hemianopia, which is basically the loss of the same side in terms of left and right of the visual field in both eyes. But you can get that with either an optic tract lesion or with an occipital lobe lesion, because all of that affects a hemifield. It doesn't affect both hemifields. So how do you know if it's occipital lobe or optic tract? Well, optic tract gives you this incongruous hemianopia because your fibers are twisting, and therefore, depending on where your lesion is, it will be pressing on different amounts of your nasal, temporal, upper and lower fibers, depending on at what point of the twist it is pressing. And therefore, you have different amounts of that hemifield being affected in the two eyes because of where you're pressing on it. So if the hemianopia is not equal on the two sides, you're affecting some part of the optic tract. I mean, if you're very clever and you've learned where it twists and all the rest of it, you can probably work out exactly where the lesion is. But if it's an occipital lobe problem, then there is no twisting because the twisting's already done. You will have a proper homonymous hemianopia. I hope that makes sense. Do stop me if I'm not making sense and you want to ask questions. You know, it's one of those things when it's obvious to you, then you just say it, but it may not be obvious to everyone else. So do tell me if I'm not making sense. So that takes care of the retina, the optic nerve, optic chiasm, optic tract, lateral geniculate ganglion, and then obviously the pupillary reflex. So the next thing is entering the primary visual cortex. So as you can see, your optic tract goes to the primary visual cortex, which is area 17 of your Brodmann. And if you think about the calcarine fissure, which is that fissure right in the middle at the back of your occipital lobe, just you have the primary occipital, primary visual cortex kind of crosses between that calcarine fissure. So you've got half of it above and half of it below. The superior retinal input comes from above, the inferior retinal input comes from below. And once again, remember, inferior retinal input means the light that comes from above, and vice versa, and therefore the image is once again upside down. So once again, which parts of the occipital lobe, whether it's above or below the calcarine fissure, is affected, will affect different parts of your visual field. But a lot of tumors are quite big and they can affect both, and therefore it becomes irrelevant. But once again, if you catch things early enough, you can probably work out where the problem is. Okay. So where exactly is the occipital lobe? We all say it's at the back of the brain. We all know it's at the back of the brain, but which bit at the back of the brain? It's actually very difficult to define. So I've got a lateral view down here, and I've got the medial view up here. You've got parietal occipital sulcus. That's very easy. That's obvious. In front of it is the parietal lobe. Behind it is the occipital lobe. So that's no argument there. The problem is you follow the sulcus down to about this point, it curves forward. So how do we keep coming down here to say what's occipital and what becomes temporal? Well, there isn't actually a physical division between these two. So it's more a functional division that at this particular point, you've got your second, third, and fourth visual cortices, V2, V3, V4. So that's areas, Brodmann areas 8, 19, 20, 21. So that belongs to the occipital lobe, and everything else that's not it belongs to the lobe in front, which is the temporal lobe down here. But there isn't an actual fissure that divides it. So if you were to go to the mortuary and you do slicing the brain, you will not be able to tell exactly where the occipital lobe is, because it's a functional division rather than an anatomical division. Similarly, when you look at it from the convexity, once again, you can see this occipital sulcus that divides the parietal lobe in front from the occipital lobe behind, but it stops. And then it's at what point do you start coming down? Where do you join? Where do you not join? Once again, anatomically, you can't really define it. It's a functional division. But somewhere in that tip is your occipital lobe, is basically the answer. Now, on the lateral aspect or on the convexity aspect, there isn't really very much to see. It's just, a very flat surface with a few sulci, but it's very hard to tell what's what there. But if you look on the medial aspect, you have a lot more to see. You can actually see the calcarine fissure, which you can only see when you look from the medial aspect. You can't see on the lateral aspect. And as we already said, the calcarine fissure is important, dividing the superior and inferior hemiretinal images. The other important thing is above the calcarine fissure is what we call the cuneus, which is basically your primary and secondary visual cortices. In front of that, so we're now crossing into a parietal lobe, that gyrus immediately in front of the parietal occipital lobe is called the precuneus. And precuneus is important because that is important for the perception of depth. So if you have a patient who has a tumor specifically there, what happens is they can see everything absolutely fine. So if you just did a normal visual field test, a normal visual acuity test with a Snellen's chart, they will score 100% without any problems. What happens is when you then put a cup of water in front of them and you say to them, can you grab this cup of water? They can't. They keep kind of doing this, but they can't judge the distance. So their hand doesn't quite reach out far enough, or they knock it over because they can't judge the distance. Sorry, someone got a question? Someone got a question? Someone unmuted? No? Okay, well, I'll keep going. So that's precuneus. Okay, so that's the anatomical side of the visual pathway. Okay, so the retina, you've got the rods and the cones, you've got the ganglion cells that projects through the optic nerve. the nasal fibers crosses the optic chiasm, the temporal fibers don't. And the fibers that crosses the optic chiasm, the inferior fibers moves forward before going backwards, forming the anterior knee of Willebrand, and then within the optic tract they rotate 90 degrees anti-clockwise. And some of these fibers end on the LGN. Some of these fibers go to the Edinger-Westphal nuclei bilaterally for pupillary response, and ultimately the LGN projects to V1. So that bit I think we're all happy with. So how do we then actually construct the image? It's actually quite creative, the way the brain interacts with one another. Image processing is, some people say it's like a camera with a lens, that's your eye, and then you're just taking photos and then it just reproduces whatever it is in front of you. But it's not actually true, because you have 3D perception, which is not really possible with, at least with the old style of cameras. Maybe with a very clever new technology it's possible. There are also cognitive aspects to your image. So when we look at something, it's not just a still image. The brain actually fills in a lot of gaps, which is why if you have a visual field defect, you don't just have half your visual field being black or gray or something like that. Your brain doesn't realize that it's not seeing it. It actually fills in the gap for you, which is why when people have a visual field defect, the way you tell is you ask them whether they've been bumping into things, and they're always bumping into things on the same side. You can't ask them, is it black on the left side? Because it's not. They don't see black. They just don't realize that the image in front of them has been processed by the brain to fill the whole of the visual fields. So although they're just seeing, say, 20%, to them, that's 100% of what's in front of them. That's why they bump into things. So that's the cognitive aspect. And I've got some examples. The first, and some of you might have seen these images before. The first one, is a picture of a man and a woman. And in both pictures, the man here is exactly the same size. So that man is the same size as that man on the left. But because on the left-hand side, we've put them one kind of behind the other, your brain automatically processes it as if this man is further away and therefore a bit smaller, but you don't feel that this man is that small. You feel that they are probably about the same size because he's further away. And this is one of the cognitive aspects of your brain. If something is smaller, it will automatically assume it is further away from you. And that's just the way the brain processes things. So you can do kind of optical illusions based on size of objects, but actually you can see when you put them next to each other, the man is actually tiny. The other thing you can see is that this is filling in the gap. If you look at picture A, you just see random bits of things, not even a pattern. But when you lay out an extra pattern on top of it, your brain automatically assumes you're seeing lots of the letter B, when actually if you go back to picture A, there are no letter B's at all. But when you fill in all these gaps here, your brain automatically makes the assumption that these bits underneath must be connecting to one another and tells you that these are letter B's when it isn't. So once again, the brain tricks you, and it's the cognitive aspect of the brain. And then the third one is this one. Lots of circles with different shades of dark and light. Basically, they're just opposite of one another, but your brain tells you this column on the left, the balls are bulging out towards you, and the column on the right, the balls are indenting away from you. And actually, if I don't know if this will work, I'm just going to come off presentation mode for a second. Can you still see my slides? You guys still see my slides? No, probably not.
No.
Hang on, let me see if I can. Here, let's see. You can see the slides now? Yeah?
Yeah.
Yeah, cool. So look at this again. So this side, it looks like it's coming out of the screen. This side looks like it's indenting. But as I rotate this slowly, just follow the balls. You can see as I change around, can you see how they all now look very much the same? And then it starts to reverse. So just follow any one of them. Let's say follow this top corner one. At the moment, it's sticking out at you. As I rotate it round, it then becomes going in and indenting, and that's an optical illusion because of the shadows that's been used. And once again, that is just the brain tricking you because it's making an assumption of what you should be seeing. Right, let me go back to presentation mode. All that just to prove that point. Right, so how does all of that actually work? So perception of any image is based on motion, depth, form, and color. I've made that point enough times now. And this can be done by multiple cortical and subcortical areas. The striate area is V1, so primary visual cortex or Brodmann area 17. All the other supplementary visual areas we call the extrastriate cortex or subcortical areas. So that's your V2, V3, V4, and then you've got the middle temporal gyrus. You've got part of the parietal lobe like the precuneus that I was talking about, and the inferior temporal lobe or inferior temporal cortex, I should say. All of that is important in visual processing, and all of these areas interact with one another. Now, I'm not going to go into all the details, because if you want me to go into details, I can turn this into a 5-hour talk instead. I wrote a whole thesis about this. You don't want to get bored about that. But there is a thing called retinotopy, which is what I've been trying to explain earlier on. All the different information that's been received by the different types of ganglion cells and the different types of photoreceptors and the different parts of your retina is projected, as you've already seen, via different fibers to different layers within the lateral geniculate ganglion, and then they're projected in different fibers along your optic tract to different layers of your primary visual cortex, and from there they are sent to different subcortical areas, some of them to V2, some of them to V3, some of them via V2 to V4, some of them via V3 to MT. So there's lots of different interactions. And the important thing is there is a structure to it. It's not a random connection. Certain types of information will only go to certain areas in your brain for the processing of the correct visual perception, whether it's depth, whether it's motion, or whatever it is. And it is the interaction of all of these things ultimately to the frontal areas, area 46, where the cognition of your brain puts all of this together and actually form the image that you see in front of you. And that's why people can potentially see slightly different things. And you may remember this very famous, I think it was a dress that was shown on the internet, and everyone was arguing about what color it's supposed to be. And everybody is actually correct, because it's just the way their brain interprets it. So you can argue for the rest of eternity and you never get an answer. Okay. And in primate studies, more than 50% of the neocortex is actually used for visual processing, compared to 11% for movement and 3% for hearing. Surely that's similar to men, 3% used for hearing. Oh, and the other thing just to mention, there are at the moment 32 different representations found in the neocortex. So 32 different types of visual information has been identified. I'm not going to pretend I know all of them. And one way to work out which area does what is by examining patients with different types of agnosia. Okay, so for example, if someone's got object agnosia, so they've got problems with naming objects and recognizing real life objects, we know that that is a problem with areas 18, 20, 21 and the corpus callosum, because when you have lesions in these areas, they have problems with the basically naming objects. But if they have difficulty recognizing a drawn object, so rather than someone holding a mobile phone and say, what is this? This is someone drawing a mobile phone and saying, what is this? We know that's related to areas 18, 20, 21, but not to the corpus callosum, etc., etc. So you can potentially look through all of these different types of agnosia and anomia, and then there will have been mice models or real life patients that they've examined to work out which area is important for what. And it's the same for speech and language. Lots of different areas within your brain. Everyone knows about Broca's, Wernicke's, and the fasciculus, arcuate about language and speech. But actually, that's just the basis of it. There's loads of other areas interacting with it that is involved in the processing of speech, whether it's the perception, the understanding, the performance, whatever. And it's knowing which bit concerns with what that where the lesion is and what you should be testing. And that's obviously important in doing an awake craniotomy. Once again, I won't go into too much detail because it's slightly irrelevant, but the primary visual cortex is divided also into 6 layers, but layer 4 is further divided into A, B, C, and C is 4C is further divided into alpha and beta. So there are actually lots of layers, but layer 4 is the layer that receives most of the input from the lateral geniculate ganglion. And within the primary visual cortex, you have lots of interneurons that projects from layer 4 to all the other layers. And depending on which layer it goes to, it would then project to the correct subcortical area for the processing of that information. So most of it, as I said, goes to V2, which is divided into your thin and thick stripes. And the thin and thick stripes then project to either the middle temporal area, or it goes to V4, which then goes to your posterior inferior temporal area, central and anterior inferior temporal areas. Not important. It's just to demonstrate the complexity of the connections and the fact that everyone talks about the occipital lobe, about vision. Actually, as you can see, most of the temporal lobe and quite a bit of the parietal lobe is also important in processing this information. And it's ultimately the frontal lobe that puts everything together. So you actually need the whole brain to form the image that you see in front of you. Forgot I've written all these things down to remind myself. There you go. This is just to show you roughly what information goes to which area. So the motion signal goes to your middle temporal cortex. The depth perception, as we already talked about, goes to precuneus, which is your posterior parietal areas. And then contour, form, and color goes to the V4, which is one of the associate visual cortices, which then goes to your inferior temporal cortices. So those are the areas involved in all the different things. Just a couple of slides left. So how do we actually detect motion? We talked about how you detect color because of the 3 different types of photoreceptors that cones have, and therefore working out the wavelength. Motion, there are 2 main types of detecting motion. One is the actual image moving. And if you remember, I talked about the torch. If it's in front of you, it shines directly into your fovea. If you move it to the right-hand side, it shines to the left side of your fovea, and vice versa. If your torch is constantly moving, then you have granular cells firing initially on the, say, right side of your retina, and then as it moves towards the other side, those cells will stop firing, and then the next set of cells will start firing. And it's that sequential firing of granular cells that will tell the brain that this light source is moving, and that's how you detect an image is moving. The other way your brain knows an image is moving is when you move your head and your eye. So if something's moving and your eye is following it, your head is following it, then that movement is obviously perceived because that's part of your proprioception. And that perception of movement, but this image staying in the middle of your visual field, tells the brain that this image is moving at the same speed or at a different speed, depending on how fast it's moving relative to how fast you are moving your head and eyes. And that's how your brain tells the speed of movement. So it's the actual light shining on different parts of your retina and causing sequential firing of your cells, and the speed or relative speed of movement of the image to your own movement that the brain uses to perceive motion. And in terms of depth, you have the monocular cues and you have the binocular disparity that tells you something is further or nearer. In terms of monocular cues, what we mean by monocular cues, these are cues that one eye can use to tell the distance of something, and it's not as accurate, which is why, and I don't know if you've ever tried this, if you have a piece of paper and you draw dots at equal distances except one of them, make one of them slightly further away from the other. If you put it right in front of your eyes, you can see that most dots are equal distance apart from these 2 dots. And if I ask you to hold a pencil and jump from one dot to the next, you have no issues because you can see it. But if you now lay that piece of paper on a table and you go down to the level of the table with only one eye and try and jump, you will miss that dot because one eye is unable to tell perception as well, and your brain once again tricks you and automatically assumes they're all at equal distances. It's quite an interesting thing. You should try it out yourself on a piece of paper. But things that your eyes can use as a cue for depth is familiar size. So if you know something is of a particular size and it isn't that size, the brain will automatically assume it is because it's closer or further away from you. There's something called occlusion. So if one object is blocking part of another object, automatically your brain will know that that object must be in front of the object that is blocking. So that gives you depth perception. Linear perspective. Linear perspective means that when you look at parallel lines in front of them, they're actually converging. So I'm sure you've all seen that parallel lines. When you look at it from above, they're parallel, but when you look at it from in front, they're actually converging on one another. They don't actually ever meet because they're parallel, but they look like they're converging. And the more they converge, the further away from you they are. And the more they are, the further away the two lines are, the closer it is from you. So that's called linear perspective. Similarly, size perspective, we've looked at already. The smaller an object, the further away it is. Shadows and illuminations changes how you perceive an object, and we did that with those circles, with the the gray scale. And motion parallax. Motion parallax is the speed of movement of something that tells you potentially how far away it is. So, for example, when you're driving in a car and you're looking outside the window, those things closest to you move away from you really quickly, but those things very far away move slower. This is obvious. You all know this is common sense. So that motion parallax tells the brain that if something moves quickly, it's more likely to be close to you. If something moves slowly, it's more likely to be further away from you. So these are all the clues one of your eyes can use to detect the depth or the distance between you and that object. And then when you put two eyes together, the binocular disparity, that is the way the light falls onto your retina. So if you imagine your fixation point on the retina, any image that's falling on the outside or on the temporal side of your retina is perceived to be closer. Because if you imagine a point somewhere in front of you and the light coming directly onto your fovea, for a light to fall onto a place that is same distance temporal to that point, that object must be closer because of the way your light is reflected. You have to draw it out to make it work. If you just get a piece of paper and just draw 3 dots and then draw 2 circles in front of it and draw lines, you'll see what I mean. But anyway, the light falling outside of your fixation point is closer. The light falling inside your fixation point is further away. So that's called the binocular disparity. And when you put all of these things together, you then have the image that you actually see in front of you. So, in summary, the important take-home messages are that the retinal image is an inversion of your visual field. There are a couple of important loops. You've got the anterior knee of Willebrand, which is that nasal inferior quadrant fiber that crosses the chiasm but moves forward in the contralateral optic nerve. There's also Meyer's loop that I forgot to talk about. Meyer's loop is the fiber that comes down onto your temporal lobe, curves forward and then moves back. So the Meyer's loop curve comes to just behind your temporal horn of your temporal lobe, which is why if you operate on the temporal lobe, you want to try and stay in front of the temporal horn. If you damage the Meyer's loop, you will end up with a superior field quadrant anopia. So that's just part of the inferior fibers curving forward in your temporal lobe before continuing backwards towards your occipital lobe. That's the Meyer's loop. You've got the rotation of the optic tracts we talked about. You've got the Edinger-Westphal nuclei, which is bilaterally innervated. And then we've talked about the different ways that motion, depth, form, and color is perceived between all the different subcortical areas. That's it. That's not too bad timing. Any questions?
I have a question.
Yes.
You mentioned the counterclockwise rotation of the optic tract. Which side does it go counterclockwise? I presume the other one goes clockwise.
Yes, sorry. Yes, that's a very good point, isn't it? Because I was talking about the right optic tract. So the right optic. So they say they turn. They turn kind of outwards, if you like. So all the fibers turn. The superior fibers turn outwards. So I guess that means on the right hand side is turning clockwise, and the left hand side is turning anti-clockwise. Yes, someone else got their hand up. I can't tell who's who on my screen.
Yeah, I think we have 2 people with their hand up. There's Amira and Mohammed. Amira, do you want to ask?
Sure. Thank you so much for your time tonight. I just wanted to ask you, sorry, I didn't catch the name of the book that you mentioned. I was wondering if you'd mind repeating it.
Oh, okay. Yes, of course. I can show you. Here you go. Yeah, this one. Neurological Differential Diagnosis by John Patton. That's probably a much newer edition. I bought this one about 10 years ago. So this is probably not the latest edition.
Thank you so much.
No problems. Any other questions? I've confused everybody. Excellent.
Thank you very much, Mr. Tsang. That was very comprehensive, and I'm sure everyone learned a great deal from the lecture. But just to point out, would everyone be able to fill in the feedback? Because it's obviously clear Mr. Tsang put in a lot of work to the presentation, so it would be great if we could all get a little bit of feedback and pass it on. I believe Lana has just uploaded the QR code.
Thank you.
Yep, I'm sharing the screen.
Oh, Mr. Tsang, we have another question.
Yep.
From Dr. Singh.
Yes.
Hello. Hello.
Hello. Yep.
Yeah, good evening. Okay, I just want to ask that will we have the presentation offline?
Yeah, I don't mind. I can send it to Lana, who can share it to anyone who wants the presentation. That's not a problem at all.
Okay, thank you. It was great.
Yeah, no problems.
Hi, I have a question if I can ask, but it's maybe, I'm sorry.
Right, go for it.
Yes, okay, maybe it's a work question, maybe, but I wanted to know if there is maybe something that, is it possible that something that we see with our visual field, and then so we basically see the colors and everything, there is a connection with maybe the dreams, so we dream seeing colors and imaging. So I just wanted to know if there is something like a cognition process, or it's just memory that comes back.
That's a good question. It's completely separate. So dreams don't really come into the visual pathway at all. It's a separate entity altogether. So you're now talking about your prefrontal lobe interacting with your hippocampus and all the higher order cortices, and it is a method of your brain to process the information that you have gathered during the day and basically filing them in the right places within your hippocampus, and so it's not really related to what your eyes are potentially seeing at that point in time. It is actually a recollection of what happened previously, often not quite. I mean, if you're dreaming you're on the beach, it doesn't mean you were on the beach before, but it's all the various bits of information that you have either heard of, saw, or whatever being processed. And so it's just images that your brain is creating rather than something that you're actually visually seeing.
Thank you very much.
Cool. Right. I shall leave you to it then, if that's all the questions. Oh, someone else got a hand up.
Sorry, just one more question, I think, from Daniel.
Of course.
Hi, Ms. Tsang. Thank you for a fantastic talk. Just a question really about like bitemporal quadranopias. Do you actually see them typically in practice? Like, do these presentations of visual deficits present, or do they tend to be, more textbook?
No, absolutely. No, absolutely. You do see them. I mean, they're never the way they paint it in a textbook, where it's like a pizza with a whole quarter that's gone. Usually, it's not quite as nice as that, but you definitely do see that progression of quadrantanopia gradually becoming a hemianopia. That is definitely true.
I was going to add, Mr. Tsang, it's Abby. Hi. We see a lot of those as 2-week wait referrals. So suspected cancer pathways often will be patient visits, optician, for a routine checkup. They identify a visual field deficit, or equally it's something that we pick up on examination when patient presents with other symptoms. So I would say it's quite a large proportion of what I see through the 2-week wait pathway.
Yeah, I totally agree. I think it's very common to see visual field defects, and just like I think as medics, we are not very good at assessing vision. When's the last time a doctor has picked up some the cards to test color vision and things like that, and I think it's like a speech and language therapist test language and speech a lot more thoroughly than we do. With all the different agnosia that I've named, I'm not even sure half my consultant colleagues will be able to name all of those agnosias. And similarly, from a visual point of view, I don't think we have someone who will test all of those different aspects that I've mentioned before. But I remember very clearly when I was an ST2 SHO in Queen's Hospital in Romford, we admitted a patient with a tumor, and I remember seeing the patient, and this is why I always remember precuneus now, because it was amazing when I took the history from the patient, and the patient was very clear. I can see everything absolutely fine. I just keep knocking into things, and initially I thought it's a visual field defect, and then I said to him, "What do you mean when you say knock things over?" And he said, "Whenever I went to grab things, I always knock over something else because I just can't judge where it is." And I just thought, oh, that sounds like a precuneus problem. Scanned him, and he had a tumor in that, interparietal lobule. And so I always remember it, which means that actually these things are not just textbook. You do see them in real life. If you look hard enough, you will find all of these things. Most of the time nowadays, we do a very shortcut neurological examination. We don't test all of these separate domains, and that's why we never really see them. When's the last time someone picked up a Gerstmann syndrome? I bet you if you examine anyone with a dominant parietal lesion properly, they will have a Gerstmann syndrome, for example. We just don't examine patients properly because we don't have the time. We're told to do all these TTAs and NADI, all these other rubbish. But if you spend time, you will find all of these things that I mentioned tonight. Yes, someone else asked a question. Oh, someone had their hand up. Someone did have their hand up.
Mr. Barts.
Excellent presentation, Mr. Tsang. I am so impressed. I joined unfortunately a bit late, but I'll get the recording. But you are absolutely right. For the juniors who are less into clinical practice, I cannot agree more that an astute clinician can localize the lesion only by assessing the vision. Absolutely right. And I have learned so much tonight that I never knew. You are absolutely right that most of the consultants don't know, but a good clinician can confirm a localization only by testing the vision. Thank you very much for reinstating the confidence.
No, you're very kind. Thank you.
Thank you, Mr. Tsang. I think there's one more person who's raised their hand. Richard, would you like to unmute yourself? Or not? Okay.
Thanks so much for the talk. It was really interesting. Just going back to the kind of question and kind of topic about like dreams. It's a question that I've asked several people and never been able to get an answer from. With kind of psychosis, is there any reason why you're more likely to get auditory hallucinations rather than visual hallucinations? It's
a good question. I think you're right. I don't think anyone really knows the answer. I don't think it's been studied enough. I'm not aware of any, say, functional MRI studies of somebody whilst they're having psychosis to see which bit of the brain lights up, for example. But certainly we know that the mesiotemporal lobe is involved a lot with, feelings and emotions, like the amygdala interacting with the hippocampus and interacting with your prefrontal cortices. And the auditory gyrus, which is the gyrus of Herschel, I think it's Brodmann area 40 and 41, but I could be wrong. But anyway, that gyrus is a gyrus right next to the amygdala. So whether it is that the hyperexcitability of that area causing the auditory hallucinations, I don't know. That would be my kind of theory if I had to guess based on an anatomical basis. But I'm not aware of any studies that actually looked at, which bits of the brain lights up during a psychotic episode. Oh, I think that was it.
Thank you, Mr. Tsang. Thank you for your talk.
Oh, you're very welcome. No problems. Have a nice evening.
You too, you too.
Thank you very much. Goodbye.
Thank you.
Thank you.
Thank you.